Okay, hello everyone. Today I would like to actually to replace some of the information which one of the students just informed me that the slides are there, but the recording somehow there's some magic in PowerPoint that it's vanished. So I'm going to go through for arrhythmia pharmacological treatments for class 2, 3, and 4 in this particular section. Okay, so next. So, um, so the class 1 of the medication for arrhythmia is already explained in the other talk, if you call it. So in class 2 is something more easier because it's something that you already learned before in other cardio-related classes, which is beta blockers. So hopefully something very familiar to you by now. So similar like the function of the beta blockers that applies across the board in a way. So beta blockers, what it does is for beta adrenoceptors itself, it's mainly located in the SA node. So it's actually involved in the pacemaker current because it decides how fast the heart actually beats. So that's why it influences the frequency of the node firing. And it also there's also beta adrenoceptors at the AV node, whereby it controls the conduction velocity by indirectly influence the calcium and potassium channel current. So therefore it influences the refractory period of the node. So you can imagine if you actually apply a beta blocker, so it actually has the negative or the reverse effect of what is the function of beta 1 adrenoceptors as mentioned earlier on. So if you look at the graph in a way, so as we all already know, if you actually apply a beta blocker to someone, it actually reduces the heart rate, as you can see here. So it actually prolongs the whole peak, so therefore it reduces the heart rate. But you can see the intensity, the height and all it's all the same in a way, right? Because it mainly reduces the automaticity. So when you reduce the heart rate, it therefore reduce the myocardial oxygen demand. So therefore your heart doesn't actually require so much energy to function because the activity is reduced. And it also increase the refractory period slightly to reduce the chances of re-entry. So details of the graph just now you can actually read through in this particular text. So it reverses the sympathetic stimulation in general, right? So it's one of the safest one to treat arrhythmia. So therefore it's one of the most useful one in a way because it's safe. However, here we mainly talk about the non-selective beta blocker. In this case is propanolol. However, the clinical usage of it is slightly more restricted in a way. So because it's mainly used to treat those with extra activity on the beta 1 adrenoceptor stimulation. Therefore, if you use a beta blocker, it will be effective. But if it's arrhythmia due to other reasons, then it might not be so useful. So it's mainly used to treat tachycardia caused by catecholamine stimulation. So especially when it's under stressful conditions, some people get arrhythmia, very bad tachycardia. So propanolol could help. So they can actually take a propanolol before the event that they know is going to be stressful. So it can be safely used in patients with long QT syndrome as well. Okay, so we go to class 3. So class 3 is actually one of the very, very useful one as well. Not because of the safety profile, but because of the clinical benefit that we can see. Okay, so details of the explanation you can see actually in the extra handout which is given in the book under the system, right? So whereby in class 3 it's supposed to be focusing on the blocking of potassium channels, right, in general class 3. So therefore it causes a prolong of the repolarization, right? You can see the graph will be stretched. So wait, where's my okay, so therefore it increases the effective refractory period. So what happens is that for this part you can see that because it extends it, so it has a high chance for it to actually cause another uphill before it completely goes down. So therefore it's actually not so favorable. However, in this whole class 3 there's a few drugs which are very, very useful. One of it is sotalol. So you might think, hey, sotalol, isn't it a beta blocker which is class 2. So sotalol is something with class 2 and class 3 activity. So details you can see through in the slide. Another one is actually called amiodarone. All right. So amiodarone is something which is very special in a way, because it actually, if you look at closely into the mechanism of action, which you can see through in the handout, it actually covers class 1, 2, 3, and 4. So in a way, it's simple in a way that if they ask you about, hello, what's the mechanism of action of amiodarone in for arrhythmia treatment, so you can literally just say everything which covers the group of drugs in arrhythmia, you get all the points, right? Because it actually is a non-specific drug in a way, but it has some specificity, but it has multiple action in a way, therefore it has multiple mechanism of action. Right, so so there's some part of the undesirable. So at slow rate, we don't really want this to happen to extend, but when it's too fast, you actually want it to extend a little bit better. Right, so therefore it reduces the overall heart rate. So amiodarone is still in the guideline, right? So it's mainly used, it can be considered and safely used in people with left ventricular impairment or people with heart failure, which is very, very important, because you have to understand that a lot of people with arrhythmia could possibly get arrhythmia due to recent heart attack incidents or arteriosclerosis and things like that. So therefore, some part of the heart muscles are sort of dead, so that's why the electrical signal goes haywire. So there's a lot of concomitant disease, but amiodarone is safe to be used in heart failure patients. It doesn't worsen heart failure in a way. However, if you look at the adverse effects of amiodarone, it's actually a whole list. So you might be surprised in a way that, hello, if it's a drug which has so much side effects, why are we still using it? Because we couldn't find much better replacement in a way. So you can see it actually causes, if long-term usage, right, especially at high dose, it can actually cause pulmonary fibrosis, which is pneumonitis 2 leading to pulmonary fibrosis, which is not good because it's not something reversible. It can cause either hypo or hypothyroidism. It can affect the liver enzymes slightly. It may cause neuropathy as well, and etc. etc. And it also have some direct effects on the cardiovascular system. So a few years back, there's a new drug that was designed. It was in the market. That is called dronedarone. So it was initially it was a hooray in a way, because it has much lesser side effects profiles theoretically. So a lot of people are quite happy, because then there's finally another better option. However, it's less popular now. It can only mainly be prescribed by arrhythmia specialists, not just cardio specialists, but those who are involved in arrhythmia. Why? Because it actually has a lot of contraindications to use dronedarone. It has a much shorter half-life. It has less effective as well in the treatment. It could cause more liver issues, and it can cause or worsen heart failure, which is something that we obviously try to avoid, because a lot of them might already have pre-existing heart failure condition. Okay, so therefore, we most of the time, like it or not, if they need to use amiodarone, we still need to use amiodarone. Okay, so the last class here is CCB, so it's the calcium channel blockers. So again, we are looking at those calcium channel blockers which are mainly targeting the heart, right? So as similar as you've seen or you've read about CCB in other classes, it mainly affects the heart rate as well. So it causes a slower or delay in the next beat. So therefore, again, similar like beta blockers in a way, because it actually reduces the cardiac myocytes oxygen requirement as well, right? So therefore decrease the excitability at the SA node and Okay, so again, it reduces the heart rate but does not change the rhythm. It's still the same pattern, right? So again, we talked about the cardio-specific one, which is verapamil, and a little bit on diltiazem. Right, so can you add beta blockers together? So obviously you probably already know the answer is a big no, right? Because they both sort of cause a depression in the SA node signal. So you don't want too much depression, because obviously you still want the heart to function. So it's definitely a no to use both CCB, which is cardioselective plus beta blocker. Okay, so there's some of a summary of the adverse effects and contraindications. Again, you can see it clearer in the handout, Right, so there are other treatments which are linked together with arrhythmia. So this is something you have to bear in mind, because arrhythmia causes the heart to actually the flow rate to be uneven, and also it can be turbulence, which actually increases the chance of coagulability. So therefore, anticoagulants is something that goes hand in hand. They're like good friends. So when you give arrhythmia, make sure you have to give anticoagulants to them as well, because again, as mentioned earlier on, there's a higher risk of thromboembolism, right? So it can be embolism in the pulmonary, in stroke, or whatever you call DVT. So these are all things that we want to avoid as well. So we have to prevent or reduce the risk. So we actually have to use anticoagulants. So it's antiplatelets alone may not do the magic already. Right, like aspirin alone, it's not a good idea. So you probably have to go for anticoagulants already, like warfarin, dabigatran, rivaroxaban, so you name it. Right, so there's also other antiarrhythmic drugs which you I already explained a little bit more in heart failure, such as digoxin. So digoxin is also a very old class of antiarrhythmic drugs that can be used. So another one is adenosine. So these are the activities which are mentioned. It's not very popular to use it. So basically it acts on the adenosine A1 receptors. So therefore causes the opening of the potassium channels and inhibition of the calcium channels. So therefore it's mainly used for termination of paroxysmal SVT type of arrhythmia.